We will move on. So my pleasure now is to introduce Colin Dunkley. Colin is a legend in the field of paediatric epilepsy in the UK. Quite apart from what he's done with Epilepsy12 and Open UK, Colin has been fundamental in the development of the paediatric epilepsy training courses that I talked about earlier on, and has done fantastic work throughout his career in this area. Colin's a consultant at Sherwood Forest NHS Trust, but of course he's the clinical lead of and the inspiration behind the Epilepsy12 audit, and it's really good that he's going to give us an update. He's also a Twitter star. Those of you who are on Twitter just kind of have to sit back in amazement at both Colin and actually Richard having mastered this social media that the rest of us are terrified of. But anyway, Colin, over to you and an update on Epilepsy12.
Hi everyone. So I've banished my dog from the house. So Lola, who's 7 months, is completely untrustable. So she's, I think she shouldn't. She should be a safe distance. So I've got 25 minutes with you. I'm going to try and show you some data, and I'm conscious we've been waiting a while to see the sort of the output of Epilepsy12, so it gives me great pleasure to use today for that vehicle. So if you could take me on to the next slide. So it's felt so, I don't know how it's felt for you, but for me this whole thing has felt so claustrophobic. It's been completely under pressure, and I'm going to try and help us escape a little bit in that I'm going to release a big bubble of data that many of you have been contributing to. And I'll try and put my sort of personal thread through this data a little bit. So next slide. It's felt like one of those escape rooms where you know you've got to get out of there at times with COVID. And then knowing we've got this data trying to come through the COVID types of problems has felt like one of those complex, impossible escape rooms with all these people inside it. So all of you as trust professionals, the young people, the patients, audit staff, and then people in the different groups and the college project team have all been in this escape room together, trying to get our story out. So many thanks to all the contributors. I hope you are beginning to see why and what it's all about. Next slide. I've been personally trying to escape from this by getting out on my bike, sometimes early in the morning, sometimes late at night, and this is the local trail I've been cycling along the Southwell trail. And I'll show you, as I was reflecting on giving this talk, I'll show you some reflections from this and try and link it together with the data. So next slide. So the timeline for Epilepsy12 goes back to 2009, and we had our first reports out in 2012 and 2014, and the current funding round is rounds 3. And we've in 2019 we published our organisational audit report and our young persons element, and today we're publishing the full report that has both an updated organisational element and a clinical element. So this is the first time this is out from today. Next slide. And these are online from today. It's a report with 3 elements. So there's a summary report, there's a bit that drills down into the organisational elements, and there's a bit that drills down into the clinical elements. So take a look, have a look, try and pick out the bits that resonate with you in your role. There's lots in there, and I'm only going to touch the surface today. So you'll know that this is an England-Wales focused audit at the moment. Our aspiration is to be UK. At the moment, we're only able to deliver this England and Wales. The organisational audit is a snapshot cut through the service provision from November 2019 and conducted by Epilepsy12 leads. And the clinical audit is the 12 performance indicators applied to the 12 months of care for all children meeting inclusion criteria from the first assessment back in, remember this, back in July 2018 when we kicked off. So we followed that cohort 1 of children through their first year of care, and then we took a cut of that data at the beginning of this year that was analysed and sense checked, and we had stakeholder agreement in trying to understand it, and then that's the reports that are coming out. So we've had registration from all 149 trust and health boards in England and Wales. It's complicated, some of those trusts merge, but the organisational audit refers to entries from 136 of those trust and health boards, and the clinical audit is from 113 of those trusts and health boards. And a few of my slides are going to look like this. So just to orientate you before I tell you the numbers, the sort of the pinstripe chart on the right is always going to have a percentage, and then each vertical line represents an individual trust. So you can see some trusts score 100% and some score 0%, and then there's always a sort of spread of score where some trusts are somewhere in between. So that's the sort of look and feel of the pinstripe graphs, and this one refers to our participation. So in January 2020 we had nearly 15,000 children registered in the system. 4,500 or so were aligned to the cohort 1, which we're presenting today. And then we had a complete data set from nearly 3,500 of those children. And that's a mixed group. So the children with epilepsy confirmed by the end of the first year are just over 1,000. So cohort 1, nearly 3,500 children, just over 1,000 children to talk about their story. And some of the data is now going to be there for you to see, and this is just a small sample of what we can see from this group. So this shows you the age distribution of our cohort. You can see that most common incidences in the first year of care. It tails off a little bit at the end, but I think this reflects children going into adult care or beginning to present into adult services. So it's fairly level across the age group. And strangely, both in this and in the epilepsy subcohort, there does seem to be more boys than girls, and that's in keeping with previous audit findings. So next slide. For the first time, we've gathered socioeconomic data for each child, and this gives you a feel for how this looks at a graph where it's split by different regions. So using postcode, patient postcodes, you can make an assessment of socioeconomic status, and you can see the least deprived groups here shown in green, and the blue groups show the most deprived group. And for England and Wales, you can see that by far and away the biggest group in these children we serve are in the most deprived categories. And then you can see the difference between regions. So each of those regions listed below are the Open UK regional networks. But look at the difference in socioeconomic profiles for the populations the different regions are serving. Next slide. This is one way of showing the heterogeneity of the children we're looking at. So if you imagine this is all the 3,500 children in our cohort, the top grey big box shows the ones who've we thought have got non-epileptic episodes by the end of 1 year. The darker grey ones are the ones who remain uncertain. Then the purples are the ones who have turned out to have epilepsy, and then the pinks are the ones who had an epileptic seizure or cluster, but then didn't go on to have repeated epileptic seizures. So that's the heterogeneous group we're talking about today, and we're particularly interested in the epilepsy group. So this is the age distribution and gender mix for our epilepsy children, which matches the overall cohort distribution. So again, more common in the first year, and a male preponderance it would see. The next slide. And then this is how their epilepsy syndrome looks after 1 year. So this is a sort of top-heavy graph showing how common the different epilepsy syndromes are. And you can see there's no surprises here, really. Childhood epilepsy with central temporal spikes turns out as the commonest epilepsy syndrome made, than childhood absence epilepsy. And then there's quite a few where they get a different or unspecified syndromal diagnosis made, or no syndromal diagnosis made, or unclassified, and then a few of the other syndromes which you'll recognise. So you can see we can learn quite a lot about epilepsy incidence, let alone quality, from this data. Next slide, please. I'm going to walk through each of the 12 performance indicators, and this is the first one. So of those children with epilepsy, how many saw a paediatrician with expertise by the end of 1 year? And in round 3, the answer was 88%. And you can see that over time that's now increasing. So from round 1, round 2, round 3, that percentage of access to expertise is increasing. And you can see how it splits across the trusts, that some trusts are managing to achieve this for all their children and young people with epilepsy. Some are having much more difficulty around this, and just seeing a proportion. Next slide. For epilepsy specialist nurses, catch up, but it's still got a way to go. So again, there's been big increase here. So round 3, we're achieving this in 69% of children and young people. But you can see there's many trusts who are not achieving this for any at all, or for a small proportion. So it's increasing, but there's a way to go. Next slide. And this is a census cut of showing numbers of whole-time equivalent epilepsy specialist nurses, and you can see in successive rounds there's been a gradual increase in numbers. So not just increasing numbers, but it looks like their reach towards the actual children is increasing as well, but a way to go. Next slide. This is about those children who should have shared care with paediatric neurologists. Do they get that? And this is fairly static, I would say, and is definitely an area for improvement. So about 60% of children under 2 with an epilepsy or needing more than 2 epilepsy drugs were our criteria. And you can see there's many children in that group who are not having evidence of shared care. So it's static and a gap. Next slide. This is the quality of the first paediatric assessment. Sometimes this is before the epilepsy clinic. And you can see this is marked variability here between services. So this is probably the performance indicator of most variation, really. So 2 in 5 children, there's elements of that first history and examination which fall below our criteria for adequacy. Next slide. Seizure formulation. So if they've got epilepsy, have we described the seizure type within that epilepsy? And again, this is fairly static. Some trusts are managing to achieve this for all their children with epilepsy, but there's a bit of a tail off for some trusts. There's some room for improvement for some trusts. Next slide. If they've had a convulsive seizure, have they had a 12-lead ECG? And this is again applied to children with epilepsy here, and you can see some trusts are really good at this, and other trusts are struggling. So about 1/3 of children overall have got no evidence of an ECG here. Next slide. MRI. So this is an important group because the MRI is part of our hunt for those with etiology or perhaps a surgically removable epilepsy, and there's still a gap here. And there's children who should be having neuroimaging that aren't. And you can see again there's a spread across trusts in their ability to achieve that. So we need to understand why that is. What's the issue here that's getting in the way? Because some trusts are certainly achieving it for all. Next slide. we've done really well, I think, with accuracy of diagnosis. So this is our indicator that's a proxy of misdiagnosis. So if you're given a diagnosis of epilepsy, have you still got it by 1 year? And this white gap in the pinstripe graph is shrinking. So in this round, we've done really well, and 97% of children with epilepsy are retaining their diagnosis. Next slide. Then some other information here about sodium valproate. So this has been in the news recently. I think in paediatrics, we're actually doing quite well, and our data supports us both communicating about valproate, but also beginning to tailor it away from females of childbearing age. So this shows that overall we had 305 children who had valproate, predominantly male, but the graph on the right shows the age distribution, and you can see that once we hit the teenage years for young females, the numbers are so small that we can't report on them, in contrast to the males. And for each of those females of childbearing age, there's evidence that they've had an appropriate conversation about risks. So this is quite supportive evidence, I think, to show we're responding to the concern regarding sodium valproate. Next slide. Comprehensive care planning. So there's 2 performance indicators around this. So in about 2/3 of children and young people, we're showing our approach to care planning is adequate. And next slide. And then in terms of actual content, there's some rooms for improvement, particularly in some trusts. So this is things like, has the young person with epilepsy had first aid talked about, water safety, risk and participation, contact with the epilepsy service established, and many trusts are struggling with this. And the idea of a welcome pack or information pack, you could see, could go a long way towards beginning to improve this care planning content at onset of diagnosis. Next slide. Healthcare planning from a school perspective is a new sort of attempt for us to reach into education, and I think this is our area of biggest concern, along with mental health in this audit. So there's maybe 7 out of 10 children from a health perspective, we can't see any evidence that they've got an appropriate healthcare plan for their time and life in school. Some trusts are achieving this, but the majority are struggling to see this evidence. Next slide. So that was our 12 performance indicators. Then just a taster of some of the other information around quality in there. This shows how the numbers of epilepsy clinics are increasing round on round. So more children are beginning to be seen in a designated secondary level clinic. Next slide. Mental health provision. So there's a lot to nudge us and make us think twice around mental health. What was striking in our audit today, that we're releasing today, is how little we're seeing and diagnosing and recognising the mental health comorbidities in children with epilepsy. So we could see evidence of mental health diagnosis is only 6.1% of the children where we'd expect to see it, and obviously that would appear to be an under-diagnosis, knowing the incidence of mental health provision. So that's a beginning to show the gap that the mice study is an example of something, an intervention that's trying to reach that gap. Next slide. Children's epilepsy service, so other children with surgical criteria getting to the KES service early. Well, not as evidenced by the audit. So if they have KES criteria, we're seeing only 30% have evidence of referral to KES in their first year. So low referral rates are a concern. Next slide. Contactability has been of interest. So I think quite a few trusts are getting there now with this. So 50% of trusts have a service where they state that the family can expect a response from someone within that epilepsy team, that epilepsy service, within 3 days. But there's a way to go with contactability. Next slide. So all this looping around audit cycles sometimes feels like you're getting nowhere, but actually I think we're beginning to see that there is really good objective evidence now of improvement, but also as we loop we're beginning to show new areas of interest and concern. So it's not really a circle of going nowhere, it's a spiral of improvement which we can begin to recognise now. Next slide. And this shows that, again, the same 12 performance indicators which I've just shown, but in a table. And the two with a green arrow show the ones where we've got statistical significant evidence of improvement. So children accessing epilepsy nurse specialists and accuracy of diagnosis, we can evidence that that's got better and reached statistical significance. Next slide. So what does it all mean? So the data only comes alive when we look at it, understand it, and use it, and then use it to actually try and improve things for our young people. So we all need to now begin to see what the story is from this. So which of the recommendations are relevant for you and your service and your role? Where's the challenge? Where do you need to take that challenge? You'll have got local reports. Which vertical bar in those graphs is your service? What's going to be your personal response, our local team response, our trust response, regional and national response? So seeing the issue and working out where to take that issue is now going to be our piece of work, and we need to turn the data into actions. And that's tricky in the current climate, but the difficulties that young people with epilepsy haven't gone away. Next slide. So things we can do is look after yourself, look after your team, nurture your local epilepsy team and your service, and create resilience amongst your team, but also establish a team if you haven't got one, and then try and build up its capability and its voice. The data entry for 2 and 3 clearly is tricky. Trusts are under pressure for a number of reasons, and COVID clearly has disrupted things. But do what you can. The audit is still live and functioning, and cohort 2 children and cohort 3 children, we need to see how they're doing. Are we getting improvement? What's the impact of COVID on those children and their quality of care? So do what you can. If you can't get all children in, get some children in, and we'll keep the spiral of improvement going. Share your work with others in your team, but also share the workload. Engage with your network and the other pieces of work you've heard about today. And shortly we'll be doing a formal survey where we ask you about ways we could improve the usability of the project. Next slide. So just a few more slides, but they're more reflections. So COVID-19. Clearly it's been a major problem. Next slide. And amongst all the voices and confusion around this, the most striking has often come from a young person. And this is just to show you that the voice of the young person cuts through all the complexities. And this was a set of remarks that we shared from one of our paediatrician's nephews around COVID. So I think this remains the most clear sense of COVID that I've heard throughout everything, and coming from a young person. Next slide. I think there's some causes for hope. So our concerns regarding improving contactability and co-location definitely are more easily achieved now with the way COVID has shaken things up. So contactability has become easy in some ways with virtual clinics and reliance on different forms of communication. So some of the bubbles are being broken up in epilepsy services as we've been bubbling at home. And co-location, I think there's opportunity for this to become easier as we try and join professionals for transition mental health and multi-agency working. So we can seize some of the opportunities that COVID's brought about. Next slide. And so is there light at the end of the tunnel? Next slide. I think so. But you need to make sure you're in the right tunnel, and this is a problematic tunnel. So make sure you're in the right tunnel, because for sure there's going to be debris or no light. Next slide. One of the lights that's coming, I think we're going to try and improve the connection of interoperability between Epilepsy12 data with patient-facing platforms and electronic healthcare records, and this will be a step towards lightening the data load and the yield from entering that data. Next slide. And lightening our data is going to be really important so that it becomes easier to put the data into the system, so the journey's much easier for us. Next slide. So we've got some usability changes coming. Pretty soon you'll be able to see your live performance within the dashboard. And then we're going to move the goalposts a little bit with regards to targets for data entry towards expected epilepsy numbers, so we can focus increasingly on the epilepsy children as a way of seeing quality for our local population. Next slide. So yeah, so find good tunnels. Next slide. Make sure those tunnels let light in along the way. Let's try and lighten the data and keep pedaling, keep our balance, and know we're appreciated on the way. Finally, contact the epilepsy team at any Epilepsy12 team at any time. Tell us how you're getting on. Make contact with us, and the team, I'm so appreciative of them. They're so supportive. So be nice to them, keep them bolstered and supported, and keep the contact and dialogue going between us. So with my final slide, just to say thank you. Look out for the report, download it, have a look, take it back to your trusts, wear your helmets at all times, and let's work towards the next cohorts and seeing ongoing improvement. Many thanks for your time and attention.